Okay, I'm super excited to have Dr. Adam Solomon with us today. Unfortunately, my partner in crime, Reza, is not able to join. But Adam, welcome, and would love to have you kind of give us a brief introduction as to your career.
Sure. Thank you for having me. I really appreciate spending the time. I'm an internist by training, and that had always been my aspiration to be a physician. And ended up starting practice in Oregon, really planning on doing that for the next 35 years. And then suddenly things changed, and ended up becoming the managing partner for the group, and then moving on and eventually getting more in depth in administrative medicine, moving down to Los Angeles, joining a very large, well-known full risk organization and learning the ropes there, subsequently moving on to working in an integrated hospital system and doing similar work, and currently with a group that's in an ACO REACH high needs plan.
Amazing. When we first met and I heard about your career arc, I was kind of blown away because you were in the whole IPA and MA space many years before it became really a big thing like it is now. So you're really like one of the OG physician executives. So take us back to the kind of the origin story of how you got started in the kind of administrative or leadership and non-clinical space.
Sure. And a little bit was just the luck of being in the right place at the right time. So as I mentioned, I started off just primary care medicine, taking care of patients in the office and in the hospital, with a group that had been around for a very long time, and very forward-thinking group. They actually were on electronic records since the late 1980s.
Oh,
it
wow.
It was the old DOS system where you had to pick a number, and it was like, the big terminals and all that kind of thing. But the community in Salem and Oregon was a pretty tight-knit community, and most all of the physicians in the community were in the same IPA. And we had some risk-based contracts for performance with the health plans. And that generally the groups did well. They got some money back each year and shared savings. And one year my group decided, the person who was the managing partner for the group decided to bring on 3 new physicians at the same time, which was expensive. We got an interest-free loan from the hospital and thought, well, we don't need to worry about accumulating money to pay back all of their salaries for the year because we'll get the savings back at the end of the year from our risk pool. And that year the risk pool didn't do quite as well, and so we didn't get any money, and so the rest of us got shorted a bit, and it was a pretty tough time, which caused me to say I need to get involved with leadership here. Once I started to get involved with planning, long-term planning for the group, I realized how much of our funding was dependent on how well the IPA performed. So got onto the board of the IPA and slowly worked my way up to be president of the IPA. During that time, another interesting thing happened in Oregon. So Oregon, the Oregon Health Plan, which is their way of doing Medicaid. And I'm not going to get into the specifics of it, but it's a very interesting way of doing it. They budgeted how much it would cost to manage the population, put in a 12% administrative cost, and we're paying that to the health plans. And the health plans were complaining that that 12% administration amount wasn't enough. And so the governor started going to the different IPAs in the state, asking if they would be willing to take over the population. And so it was Governor Kitzhaber at the time, who actually was an emergency room physician from Salem way back before he became governor. And I still remember that meeting where he said, look, I know you're taking on a big risk. I will make sure it's okay, but I really need you to do this. And so we did. We took on the complete risk, capitated risk for management of the Medicaid population in the entire Salem and surrounding area. And so that was my first sojourn into taking on full risk. And there were some barriers in the way they set up the Oregon Health Plan that helped protect us somewhat. But ultimately, we were running with a 6% administrative cost. It was very cheap to run the program. So we ended up starting to accumulate all of this money and needed to do something with it. So first of all, we started paying all of the providers that were taking care of the Medicaid patients more. So they were ultimately getting Medicare rates, even though that was not happening anywhere else in the country. and also bought an EMR that was, very inexpensive to use, so it was deployed so all of the providers could be on the same EMR. The other thing that happened is because we were the full risk Medicaid group, we realized that when a woman got pregnant, because she had the baby, she was going to be on Medicaid. If she was homeless, once she flipped over, we were going to be responsible. So we need to get there earlier on some of the women in the community that were on drugs, and actually brought on a woman that had been homeless and on drugs, who had delivered, who was clean, to start going out in the community to find women, identify women like that, and get them to join, get clean, and have a clean baby. That was very successful, and so we started a philanthropic medical foundation.
Wait, can I interrupt you? I want to make sure I fully understand what you said. You were so forward thinking. You anticipated who's going to be on our books in the future. These were not part of your full risk population yet, but you were already identifying them and intervening on them.
Correct. So, well, they weren't there yet, but we saw historically that they would pop on and be very expensive, because then we would have the child. We said, well, you need to do something about this, and so we started that plan, and then we needed to fund it and some additional. So we started the philanthropic foundation.
Wow.
And similarly, the state funding a cut on the a methadone program, or the drug treatment program. So we started to fund that out of that. The other thing that started happening was the premiums for physician offices were very high. Historically, physician groups or provider groups are very expensive. They tend to use healthcare a little bit more because they're aware of what their options are. And so just to step back, grocers is a great example. So typically, all the grocers in the community can get together and set up what's called a mutual employee welfare trust, where, because they're all in the same industry, it's basically they become self-insured as an industry. So we started was nicknamed a MIWA in our community for physician offices to compete against the plans, and at least, whether they chose us or not, it would give the provider offices something they could hold up and say, look, I could get this if you don't give me a better rate. And so this is in the early 2000s. After a couple of years of that, we realized the paperwork to switch that to a Medicare Advantage plan was pretty minimal, because we had gone through all the work, all the regulatory stuff. And so the CEO of the IPA and the medical directors, and I was at the time starting to work more part-time as a medical director for the IPA, as well as continuing with my 75% practice as the clinician, and then also part-time as the managing partner for the group, help them develop what should the benefits be for an MA plan, so that we know we're encouraging patients to be compliant and manage their diseases well and still perform. And we calculated out we only needed 300 MA lives in order to make a profit. So it wouldn't be the new plan. All the physicians in the community who would be part of the plan are allowed once, when they sign up a new plan, to tell their patients, hey, I just started with a new MA plan, them out there. But once you publish MA, the provider, you cannot towards the plan.
Hold on, Adam. We're having some audio problems. Your thing keeps breaking up.
Not sure. Hear me okay?
Yeah. Okay, let's keep going, and then
tell me, I'll push them out. So you started the MA plan. Actually,
no, it's not working. Maybe we go back to just your regular mic.
Am I on? Can you hear me?
Yeah, it's
Sorry.
better.
So there's I actually have a picture of my face on a billboard advertising this MA plan, which is actually also on the back of a bus, which is pretty funny. So that was my first introduction really to full risk, both on the Medicaid side as well as on the Medicare Advantage side, and getting that full taste of leadership as an administrative position.
Wow. Okay, so much to unpack here. Let's start with just IPAs as a general concept. Some of our folks might not be, some physicians don't know this concept at all. So give us like the 101 version of what is an IPA, why does it exist, and so a little bit of history, I guess. So I guess you guys were partnering with HMOs if this was happening in the 80s, or like who were the health plans that you were partnering with?
It was a long time ago. I think I can't remember the names of the plans, and some of them probably don't exist anymore. But yeah, it was the mid 90s around that time that we're doing for those plans. So an IPA is, it stands for Independent Physicians Association, and it is exactly that. It is a group of independent physician practices, and for the most part, the IPAs I've been in, typically you're talking one doctor offices, 2, 3, maybe 4. If you get an office that's much bigger than that, it's a little unusual, but it does happen. My group at the time was around 15 physicians, and then plus some APPs. So the centralized entity can take risk on behalf of that IPA and does that contracting, and that's their network that's provided to the health plan. And in effect, the IPA becomes an extension of the plan for managing the risk and the costs for those physician groups.
So this IPA that you were part of in Oregon, it presumably had what, hundreds of small physician practices that were part of it?
Yeah.
And were Oregon and California kind of ahead of the rest of the country in this sort of stuff?
Yes, even more so probably California, just because of scope. The size of the population was there. So I'll take it to the next step. When I was doing all of that, I realized I enjoy this work. I think it's really interesting to think about how can we improve the outcomes for populations. The other part that was going on was some legislation that was occurring in Oregon at the time that, well, we also started with the money that we're making. We also started a political action committee. So we started meeting with the legislators and talking to them about that. And I realized there were not a lot of physicians speaking out on behalf of physician practices and who understood healthcare. The people in legislation making those laws didn't understand it at all. And the lobbyists would say, if you're not at the table, you're on the table, which was very true. And that pushed me to start recognizing I had plenty of physicians that we're working with that were great. They were giving wonderful care to their patients. And my patients would be well managed if I turned their care over, but there was nobody that was speaking on behalf of the physicians. So that's what pushed me to kind of go to the next step and say, I want to get more education, understand the business of medicine. So I signed up for my master's in medical management at USC, and that experience was enough to get me to realize I really enjoy doing this, and this is what I'm going to do. So then I moved down to Los Angeles and joined an organization called the Heritage Provider Network. So this is an organization owned by Dr. Richard Merkin, who is an emergency room physician out of Bakersfield, who is really one of the true OGs of this full risk work. So this is again back in the early 90s-ish, so a little bit ahead of us in Oregon. But they would set up these type of networks. We started in Bakersfield and then expanded to Victor Valley, and they have one in Palm Springs. But they would take on that full risk for the health plan on behalf of the health plan, and then manage who that network was. And he made enough money, he kept expanding. So when I came down to LA, they had just expanded into the Los Angeles area proper. And that was my first move into that more organized structure at a much larger scale for full risk management, commercial HMO, and Medicare Advantage.
Talk to me about the okay, so when you were doing this, did the various medical groups that were part of the IPA, were there a lot of specialists? Like, how do you control specialist spend? Because that's a huge, if you're taking full risk, that must be scary, right?
It's a huge issue. So in general, an IPA that's taking risk, there aren't, so we'll say, so for example, the last IPA that I oversaw, Greater Newport Physicians, if I'm asked, is an IPA of 2,300 doctors.
Okay.
But really, the IPA was the PCP. So there's 150 primary care physicians who are the ones, because you identify who the PCPs are. The patients are attributed to your organization in a managed care full risk situation based on their attribution to the PCP. The patient picks the PCP, and then now the plan knows this patient belongs to you, and I'm going to give you that money ahead of time.
Yeah.
So that you can manage the population. The specialty network is simply who you as an IPA choose to be your preferred network for the specialists that I want to have in, which is, it can be a challenge, figuring out who performs well, who manages appropriately, cost effectively, has good outcomes, good patient experience, all of that kind of stuff.
So okay, if I'm hearing you correctly, the PCP was the quarterback and the risk was essentially being delegated to them, but the risk was not trickling down to the specialist level.
Correct.
Okay.
And to this day, I'll say through all of these risk-based contracts, including the ACO work, there is still not a good structure to have the specialists involved in that risk portion. There are some ways of doing it, but that's a tool too.
Yeah, I think it's one of the biggest topics right now in the value-based care space is how do we get the specialists on board, right? And people are experimenting with various different bundles and et cetera. So talk to me about the challenge where you're a primary care doctor, you're running a fee-for-service practice that maybe, I'm presuming, a small subset of your patients are part of this risk-based arrangement. How do you even keep track? John is a risk. I'm taking risk on John, but not on Mary. And does it change your behavior and all of that? So that's kind of question number one. And the second, as part of this, is who actually bore the risk? Was the IPA bearing the risk, or was it actually at the individual physician level?
So I'll start with the second question first, because a little bit easier. Is the IPA is who bears the risk.
Okay.
And then the IPA can decide, do they somehow cascade that down on the physicians or not? For the IPA that I was in Oregon, it was pretty easy to maintain the risk because the administrative fees were so high for us. We just had all this extra money. It was no worry that it was going to be a problem. And in California, you have to have a certain amount of reserves in order to take that kind of risk on.
Okay.
Sorry, now I just forgot. I should have answered the first question first.
Yeah. So then, if you're a practice and you have some fee for service, how do you keep track of that? How does that all work?
Yeah, so it ends up being, in a way, a little bit easier on the HMO full risk side and on the ACO risk side, just because of the timing of the notification and the potential for patients to come in and out. But once the patient is attributed, and the at-risk entity will be getting a list of who are those patients, that centralized entity knows, and depending on the network, can help put that information into their EMR so it somehow shows that's there, or can just provide some sort of mechanism, a portal or some other information so that the offices know. And it became pretty important not just to work with the physicians taking care of the patients in the population, but also to work with the managers of the offices, because ultimately they were the ones that were responsible for identifying and managing and making sure those patients get taken care of. The other part is, if you do it right and you pick the right PCPs to be part of your IPA, if you're going to take risk, the big thing is, I don't want them to have to think about patients differently. Doctors hate that.
Right.
So I just want to pick the providers, the physicians that perform really well, and then they'll just do a great job. I don't need to keep hassling them. I don't need to, and the things that might slip through the cracks, that's where the backup team does that outreach and fill in those gaps, so that the physician can focus on the patients in front of them at the time, whether they're in the risk product or not.
Okay, so I have so many questions about this. Okay, so if the IPA is generally actually the entity carrying the risk, and it's not cascading down to the physician, then what does cascade down to the physician? Did you have up and downside bonus pools for the docs, or how did that all work?
Yeah, there were upside. In essence, it was upside only risk to the physicians.
Okay.
And that's the way most of these are structured. Once they're performing well, you get money and you give it out, and you've got enough in reserves that if you were to be short, you're going to be okay. And if one of those plans continues to not have a shared savings in it, you cut them. You just need to be very proactive, and you have to remember. So you mentioned the 1980s. Just to kind of go back, it was somewhere around this time. There was this push for organizations or companies to, and it was basically PE, to start buying physician practices for this HMO risk. There was one called FICOR, there was one called Med Partners, and they thought they would do well. And the issue that came up was a concept called IBNR, incurred but what's the word?
Incurred but not.
So recognized. I'll say so. The bill service gets done. The bill gets delayed before it gets submitted. It finally gets submitted, and then it gets submitted, and then it comes back, and it gets, and so, is that cost there or not? When do you recognize the cost? Because you may not be aware. You're not going to be aware for a while that cost happened. That was a concept that a lot of physician practices didn't understand back in the early 90s when they were getting into these risk-based agreements, and that's why they went, because it looks like you're doing great. Oh, look, this is our cost, this is our utilization, it's all the way down here, and our money's here, we're wonderful. And then the bills come due, and you didn't account for those because you spent money and you get killed. So that sophistication of recognizing all of that is really, really important. So once you have the analytics to be able to anticipate what's not here that will be coming in,
right?
Then you also are going to look at how is each contract performing, and if it's not performing well, you need to either renegotiate it and get it better, or you need to get rid of it.
So in the typical IPA arrangement that you have experience of or knowledge of, is the IPA contracting with multiple health plans, or it's typically like one big one for the area?
Generally, it's multiple. If you don't want to generally put all of your eggs in one basket. Now, some the healthcare system in the United States, there are some communities. The state of I think it's North Carolina or South Carolina. Blue Cross Blue Shield is 70% of the population. How do you get away from that being the big
right?
But most areas have, unless you're really rural, have a fair number of options, and you want to try to get contracts with several just to kind of buffer them off.
So was that ever a problem where? I remember, okay, so when I was at Optum and we were trying to interact with all the various IPAs and the hospitalist groups and stuff, and we said, well, we have all these services that you can tap into, right? Because and they were like, well, but we're talking to 5 different health plans. We can't keep straight, like, which health plan has what sort of resources that we can connect to. How did you guys solve that?
Right, so that's an issue if you're going to the practice. If you're an IPA, and you have these multiple contracts, even though they're going to vary, most of it you're going to take on. If you're capitated, you're taking that risk on yourself. So all of those additional services, unless it's outside of that capitation, so it brings up a concept called the DOFR. So that's the Division of Financial Resources. When you get into one of these arrangements with the plan, you start off with this DOFR, and the DOFR describes this is what you, IPA, are responsible for financially, and this is what we, the health plan, are going to be responsible for. An example of that's pretty common would be out of area. You get a patient that you're taking risk for, and they end up in a hospital in some other state somewhere. You shouldn't have to take that risk on. So that would be retained by the health plan. So all of the rest of depending on what those services are, if it's not on your side of the DOFR, then you want to be aware of it, and your central team might recognize that a patient needs something and can make that connection. The physician offices, they're not going to track it. It's just not going to happen.
In an IPA arrangement where you're getting capitation for total risk, are you typically also the entity then reviewing claims and doing denials, or is that still staying with the health plan?
It varies. So in the organizations that I have been in, so up in Oregon, and then also with both the Heritage Provider Network as well as Memorial Care Health System, all of those, we pay the claims. And there are certain super benefits to being the one that's fully capitated and then paying all the claims, because you can identify things. And it used to be you had the flexibility to deny and prior auth services to specialists that weren't your preferred network. You would just, if you were to request, they would request a certain service, you could say no and then not pay for it because you're the one who's paying and decide not to pay. It's become a lot more difficult to do that nowadays. In my work with Agilon and some of my other work with other groups nationally, it's amazing. These national health plans, when you go to them and say, hey, I want to be capitated, give me the money up front, they all say, oh, we have no idea how to do that. We can't. It's just too complicated. Like, but you're doing it over there. Yeah. Oh, we don't know. That's a different group. We don't have any part of that. So it's pretty rare outside of Southern California, a couple of places in Oregon, for groups to be fully capitated, and the other word is fully delegated, where all of that management, all of that is done by the group.
When you're not delegated for claims, there's a big problem, which is then you don't have visibility into the claims data that you're taking risk on, right? Yeah. So talk to me about that.
And that's one of the reasons why a lot of sophisticated groups in this space got into the Medicare ACO. So I was around for the Pioneer ACO and for NextGen ACO, and I was with groups that were performing very, very well in managed care, full risk, delegated, taking care of it all. You switch to one of those ACOs where Medicare is the one receiving the bill and paying the bill, and then you find out about it a few months later. You just lost huge tools that help you to manage your population. How do I identify somebody that just got diagnosed with a stage 3 or stage 4 cancer that's going to be starting on some really expensive chemotherapy that got admitted to the hospital, and I don't know it until 3 months later? That's a problem. It makes it a lot harder.
Okay, so talk to me about when you're the physician in this IPA arrangement. One of the big challenges that I see in value-based care is there's so much churn of patients from one arrangement to another, from one health plan to another, that a lot of the risk-bearing clinicians are really focusing on keeping interventions that keep the patient healthy this year versus 5 or 6 year investment where you're like, well, they're probably not going to be in our arrangement in 6 years, so it's not worth it for me to intervene on those sorts of things.
Yeah. So it's back in the regular HMO arrangements and even MA, that changing doesn't occur very much. For the most part, those patients are getting their coverage through their provider or employer, and people don't flip around their jobs that often. In an MA, seniors historically don't change their plan that often, so you get stability there. It makes it a lot easier. In Medicaid, they pop on and pop off of the lists very often, and that is a very challenging population in multiple ways. And in the ACO world, again, that is a terrible problem, depending on how frequently they get attributed and how they get attributed. We could spend an hour talking about the different attribution methodologies and the risks and benefit of each of them, because there's nothing perfect. But we had experience with one of the health plans where their attribution logic occurred quarterly, and they didn't get us the information until a month after the attribution calculation occurred. So that was frequently a problem where we would have a patient, they would have been ours for a month. We didn't know. They had a bunch of expenses or got involved with physicians that we probably wouldn't have preferred they go to. And then we find out about it after the fact, start to clean things up, and then they're off because they switched somehow and their attribution changed. But we don't find that out for a month afterwards. So we're spending all this time and effort to manage them, and they don't want to talk to us. They're not even ours anymore. So that is a huge problem, and that's why understanding how the patients are attributed and getting that information as quickly as possible, and both understanding how they're attributed so that you can anticipate, but also how can you increase the odds that patients don't flip on and flip off as they do, because that's very frustrating.
So I guess a related question then is, how much does the patient even know, and what say do they have in whether they are delegated from a health plan to a risk-bearing provider? whether it's an ACO model, an MA model,
Yeah. So in again, in managed care, it's easier. So in MA and in MA HMO and in commercial HMO, the patients know I need to pick somebody, I need to have a PCP, I need to see my PCP, get a referral from my PCP. That makes the whole thing easier. So when the team, the centralized IPA team, is reaching out to the patient, they're calling on behalf of Dr. Mohseni,
Yeah.
And so
well, but Adam, okay, so let's say I sign up for a Medicare Advantage plan, okay? If I sign up for a Medicare Advantage plan, yes, I must choose a PCP. But how do I, as the patient, know if the PCP is in some sort of risk-bearing arrangement? Because they might not be, right?
Yeah, and it's funny, in California, those patients that are managed by a risk-bearing entity, if you ask them, who's your insurance?
Yeah.
They don't say Scan. They don't say it's United.
Yeah.
They say, oh, I have GNP insurance. I have Optum. I have Memorial Care. They think their group is their insurance, even though the group isn't the insurance. The group is just a delegated provider underneath the insurance. Yeah. The cards actually show the group name on there. Mm. And it's understood well enough that patients will pick the delegated group as their provider because they know that's the network that they're going to get, because the networks overlap a lot, but they're not identical. In other places and in the ACO world, it's a huge problem. And this is, again, another contributor to why a lot of groups fail in ACO, is that the patients get attributed and they don't know that they're attributed. They don't know an ACO. You mention the name, they don't know what you're talking about. And they think in typical ACO world, I picked a PPO. I get to go see whoever I want, whenever I want. What are you telling me in trying to manage my care? I'm not in managed care. If I wanted that, I would have picked that. For a couple of our ACO, commercial ACOs, when I was with Memorial Care, we were able to get them to differentiate two different products. One was where the patient would know and they would pick that ACO and get a lower premium. And this is at the employer level. And the other one was where the employee would pick the full PPO, but if they saw one of our doctors, they would be attributed. So they didn't know that they were in the ACO versus the ones that knew that they were in the ACO and they picked it. And the way that they were managed was very different. And in our contract, we were actually a direct-to-employer provider for a national company that you'd recognize. They did this, and the costs for this population that was in the ACO but didn't know they were in the ACO was literally double what the cost for this population was that was in the ACO that knew they were in the ACO.
Oh my gosh. Wow. Okay, let's switch gears a little bit. Let's talk about, there's so many startups and vendors that are building solutions today for the risk-bearing entity as the buyer, right? And they're typically focused on the health plan as a buyer. I've often argued that there's this whole IPA market and risk-bearing medical group market where perhaps it's easier to sell into. Maybe the sales cycle is a little bit shorter and easier. What are you seeing and talk to me about that. And let's say I do have a product or solution. How do I even know what are the IPA entities out there? It's not like they're like big public names, right? So and how do I even know which doctors are taking risk in what sort of arrangements?
Yeah, that part is really complicated. So one of the, a lot of times people will go to the health plan thinking, well, they're the ones who are taking on the risk, and that's where I want to sell my product to because they'll understand it. And you don't get very far because the health plan is a huge bureaucracy, and most of the time the health plan realizes they're not actually touching the patient. They're not managing the patient. Right. You receive a letter from your health plan, you're throwing it away. You're not even going to read it unless you think it's like some weird delayed bill or something like that. It's got a bunch of words and doesn't have a number in there. You just toss it. And so things tend not to be terribly successful in that direction. And for the delegated groups, if the health plan comes along and says, hey, we want you to use this, If it doesn't integrate in with my systems,
Right.
I'm not going to use it. I'm going to be a barrier to the implementation of whatever that is. So how do you find the groups? It historically has been pretty tough. The two ways that I would suggest doing it, one is with the conversation with the health plan to find out, do you have any groups under your wing that take risk? Depending on the kind of risk, even if they've delegated away a fair amount of that risk to the group, the plan still has a good bit of risk. And because most of it is risk sharing, it's rare for them to fully capitate and give all the money or 85% of the money away. So they have some risk. If they have a risk-based group, they will connect you to those groups and make that introduction and help identify who they are, because it'll help them both. If you don't go that route, most of the groups that are taking risk are in some sort of ACO arrangement. And then you can look at a group like Delegated or Agilon or some of these other organizations, or you can even go on the Medicare website and look for who are the ACOs or who are the groups that are in the various ACO type arrangements through Medicare. If they're taking that risk, odds are they're taking some other sort of risk. And the information, because it's Medicare, they're required on their website to put who the main contact is, what their email address is, what their phone number is. So it can really save you time to find out who the leader of the structure is that is running that IPA. You may not get down to the provider level, but at least you'll get down to the IPA or overlying MSO level.
I'm sure there's some sort of, I don't know, conferences or associations where IPA leaders get together. Is there such a thing, and talk about best practices and vendors they're using and stuff like that?
Yeah, so I mean, historically, the AMGA was where the medical groups would get together. They still do, and AMGA has started to come further along. They used to really be very fee-for-service focused, but they are starting to come along in the risk-based stuff. There's a conference by a group called America's Physician Groups,
APG. Yeah.
They have two huge conferences every year, one in San Diego, one in Washington, D.C. If you want to learn more about value-based care, it's always been the premier conference to go to. And then they also provide a ton of webinars, free webinars, and other services that you can use to understand how to do value-based care from, again, groups that have been doing this for literally 45 years. NACOs, National Association of ACOs, also it's a new organization, but they have become very, very big in the space as well.
All right, let's switch gears. I want to understand the money a little bit better. So in a delegated, in a fully capitated delegated model where an MA plan is delegating to a risk-bearing medical group, I don't understand what happens to the MLR. Like, I don't even know how to phrase the question properly. Like,
I know what you're asking, because it's becoming an issue in California, because there was a law passed that is going to impact how costs are distributed, where they're going to be attributed to. So the health plan at the MA level is required to have a medical loss ratio above, I forget where it is now, 85,
yeah.
5%. So the interesting thing is, in this delegated capitated model, historically, the MA plan would take 85% of the premium and give it to the group and say, here, you manage population in that 85%. We're going to keep the 15% on our side of the DOFR for what we're responsible for. So, and this is a big thing for like a group like Optum. So the health plan puts that money into the group. Now the group is spending some of that money on their infrastructure.
Right, they have their own administrative costs.
Right, but those administrative costs are being done by the provider group. So the health plan looks at that as that's money going to patients. That's medical expense. Where in the reality is, it's not really all medical expense. Some of it is brother, and you have all of that gray zone. When are things that are being implemented? So like a risk stratification structure in the group to support that. On the one hand, well, that's administrative. On the other hand, you need to do that in order to manage the population of patients, and by identifying those patients, then you can focus your attention on those that are the highest risk. So is that administrative or is that medical loss? That's a big part of the debate that's going on now.
Amazing. Okay, let's switch gears to what are you doing now, and talk to me about your current role and current company, if that's okay. Yeah.
Sure, no, that's fine. So I'm with a company called CareConnect MD. They've got a few different parts. The oldest part, which has been around since I think '97, is a SNFist group, basically a
Okay.
medical group that takes care of patients that are in nursing facilities, both on the skilled side and on the long-term care custodial side. And they'll do that on behalf of a few different populations. Some are just the patients that are there under Medicare that the facility says, hey, could you guys take care of this patient? But others are on behalf of these value-based groups. So we do it for Optum, we do it for Memorial Care, Greater Newport Physicians, and then a few health plans like Molina and Blue Shield. So that's one part. Another part is a palliative care company that basically manages patients who are not quite ready for hospice, but go in the direction they need their needs cared for. And fortunately, since COVID, a lot of that work is able to be done remotely. You don't need to be on site and seeing patients for that. It's usually done in patients' homes. And then the third part, which is the newer part since 2021, is the ACO Reach High Needs group. And to be attributed into the Medicare ACO Reach High Needs, the patient has to have a RAF score, so that's a whole other conversation, that's at least 3 or 4. So this is a very sick population, or they've got some kind of significant mobility issue already underlying it. So given that we were already in these SNFs and managing these patients that, there's a reason why they're there if they're in custodial long-term care, it became an easy population for us to say, well, we'll take over the management of that population. The other cool thing, not to get into weeds on this product, is that unlike most all of the other risk adjustment factors and all the other ACOs, which are you make the diagnosis now and you get the difference next year, in the high needs product, you make the diagnosis now and you get that money now and back to when they first got attributed to you.
Oh, I didn't know that. That's really interesting.
Yes, because the patients, these are such sick patients, they might not make it to the end of the year. Forget about getting extra money next year. The mortality rate is like 20% or maybe higher. The big population is going to die within 1 year. So that is, even though the group in Southern California is the main group, they have groups in 14 other states and are licensed in all 50 states to do the ACO Reach High Needs.
Amazing. And then are you doing work in the venture space too?
I'm part of a structure, a group called Scrub Capital. I'm a limited partner in Scrub Capital, where it's an organization that is primarily clinicians of some sort, so physicians, nurses, pharmacists, and so forth, and they do investments through their general partners that identify the opportunities, and everyone gets to vet and everyone can input and work, but that ultimate investment's there. And then I'm also doing some consulting work. So I'm still a consultant for Agilon. I'm a consultant for a company called Guiding Patients. I was consulting for Delegated Health, but they ended up being bought by a larger entity.
Got it. And then, Adam, everybody has AI on their mind. So in this places that you swim in or whatever, what are you most excited about? Like, where would you like to see AI in the work that you do?
I think I'll give you 2 spots. One where I've seen a lot of contenders there, and the other one that I have not seen them, but I'm sure they're out there. So on the one that I've seen a lot of is really enabling the physician to manage their population really well. And so not just that ambient dictation where it transcribes very well, but it's able to pull out information from the chart, so it surfaces it. I don't need to spend the time to dig through when was the last echo, when was the last colonoscopy, have I missed this patient who's got heart failure with reduced ejection fraction, putting them on an SGLT2. I just want if it just tells me all of this stuff, it will make my life easier. And then if I have, say, a new grad, or I have maybe an NP that's not as comfortable with some of the complexities, this tool will help And it can also help me with that documentation problem of making sure I capture all of the codes and all of that. There are a lot of contenders in the space. Whether they're able to do all that yet or not and do it well in multiple modalities, that's a whole other question. On the other side, what I haven't seen a lot, but I'm sure there have got to be some, is on that managed, I don't say managed care, but that risk-based space. So more real-time risk stratification and identification and surfacing of those patients that need the attention of the team now. Right now, a lot of groups have algorithms and other things to kind of bring it up, and then it's up to the care manager to say, oh, okay, I got to call this patient, I got to call this patient, I got to call this patient. Well, if I can have the system do all of that work, and then in addition, with AI, I don't have to have a human call. I can have, and so instead of having one person who can only reach out to 30 people in one day, because half of them aren't going to answer, I could have an AI reaching out to thousands of people in one day and continue to work on that until they do answer and figure out what is the right modality for them and communicate them and through texting or whatever else.
So it sounds like that would be some system that, one, has access to your medical records, two, has access to like real-time ADT feeds, so you know like who just showed up in the ER. Three, probably has some access to patient data real time if they're on some sort of like RPM type, or maybe they have a CGM or something like that, right? And then pulling that together into this sort of watchtower thing, and then automate. So like it can identify, it can risk stratify, and then it can intervene.
If you can do all of that and be aware of benefits real time, so it knows when the patients come on and come off, that would be great.
Amazing. Okay. Any last thoughts? Where can people find you online? And any last thoughts for physicians who are, let's say, early or mid-career and thinking about getting into the value-based care space or similar work?
So I'm on LinkedIn under my name, and I'm also on Twitter under IMDOCUS, is Internal Medicine Doc US, or IMDocus is my, it's also under my name as well, so you can find me on Twitter. Not quite as active on there as I used to be, but still post some interesting things occasionally. On LinkedIn, I had posted a lot of information over the last year on, excuse me, value-based care and MA and stars and quality and risk adjustment, all that kind of stuff. I think, going to a few conferences that we talked about by those organizations, I think is really, really helpful. It will give you some connections and start to hear the language more regularly. I think looking for those entities in the area that are already doing risk and seeing if you can have conversations with those organizations. A lot of them really like to talk about what they're doing. They're very proud of their work, and it can give you some insights. And because it is still relatively new for most of the country, there are no questions that seem too basic or simple. They're very, very open to that. So I think those are places to start.
Amazing. Dr. Adam Solomon, thank you so much. This was so great. I feel like I learned so much. Thank you, Adam.
Oh, thank you so much, Alex. It's been a great conversation.